Hi, my name is Shabir Moosa. I am the Executive Coordinator of the African Forum for Primary Health Care, and I'm going to talk to you about advancing primary health care in Africa. We cannot talk about primary health care without understanding the history of Africa and some of these challenges that still affect Africa. Colonialism for 300 years provided Africa with a legacy that's been hard to overcome. And even though post-colonially we had freedom to be able to try out different things, assert the importance of people's human rights, that was a very short-lived affair, as the colonial powers wanted to interfere and were trying to protect their vested interests in Africa through large institutions like the IMF, World Bank, or through corporates that work and operate in African countries. And they have eventually, through neo-colonialism, pushed agendas that are not very supportive of the African development agenda. I think a key change came around at the turn of the century in 2002 when the African Union was formed. It certainly took a step forward and built a much more stronger pro-poor agenda. In fact, the African Union was not only trying to assert itself in the midst of neocolonialism and a global agenda that wasn't suiting it, but also to try and find ways in which Africans can come together, set up the standards by which they want to proceed, and to be able to hold the various African governments to account and urge them to move forward. It is certainly a much more vibrant organization than the Organization for African Unity that preceded it. Of course, in 2020, we had the COVID-19 virus, which has really knocked all the efforts and made it difficult. It also has shown some opportunities. So if we have to go into the history of primary health care in Africa, I think one seminal one is to remember the CARC's efforts in the 1940s to develop community-oriented primary care. And there have been other efforts as well, but this one has been historically noted. In 1978, for most of us, our conscious memory of primary health care starts with the Alma-Ata Declaration. Certainly there have been lots of efforts in Africa that's fed into it. But we remember that as the beginning of primary health care, and it was an important global document. Unfortunately for Africa, the agenda has been driven by foreign agendas, both of governments as well as corporates and large institutions that have driven the agenda that of cost effectiveness, which is really often mostly how do we get the cheap results rather than the best results. UNICEF came along with Gobi FFF in the 1970s, 80s, and this was the sort of nature of verticalized programs that did not prioritize comprehensive primary health care. And then it's become really very evident with the HIV/AIDS pandemic, epidemic in Southern Africa, that these verticalized programs were dominant and pushing the agenda. And that's been a characteristic of the last 20 years that I think many of us and many policy makers are fighting against and not very effectively. I think in the 1990s there were various conferences that tried to promote community financing, community health development to no real effect. In 2001 we had the heads of state declaring in Abuja that they will commit 15% of all their total government spend to health, and do that by 2015. And we are in no ways achieving that. There are only a few countries that have actually gotten there. So in 2006 also there was an important declaration in Addis Ababa on community health. And what I think is really useful noting is the fact that it is stepping towards this sort of growing conversation around universal access to health care importantly re-emphasizing the need to empower communities, and then for the first time in Africa spelling out clearly the importance of district health services and improving finance. And I think that has been sort of the beginnings of the conversation of a stronger decentralized healthcare system. It continues in 2006, where the actual report of 2006 spelt out this need for establishing functioning healthcare systems, investing more in health, and building, delivering essential health services close to community as possible, and seeing the district health service as the way to do that. And I think the regional committee also did, reflected the same, but strongly advised a bottom-up approach. Well, in 2008, around the time of the World Health Report on primary health care, there was an Ouagadougou Declaration, which in fact pointed out the challenge of the commitment of African governments that were not translating into action. And the issues that were raised that behind this were that there were weak structures, inadequate attention to primary health care principles, and inadequate resource allocation and political will in Africa. It urged a primary health care approach, again decentralizing health services, and then having intersectoral collaboration. The idea behind primary health care in Africa was, as was being embraced universally, was that it should be comprehensive, continuous, integrated, community-based primary health care, and that it should address various issues like human resource, finance, technology, and partnerships should include the private care, private practice, private sector. I think it still reflected the challenge that at the time of verticalized programs, that the document actually says urges governments to use priority programs as entry points to strengthen national health systems using primary health care. In 2012, and this is just a little bump on the way, when a document by WHO on how to scale up human resources for healthcare broadly had 6 strategic areas very important to primary health care. But in the document itself, even though HRH was a priority, it did not mention primary health care except as a slight mention at the beginning and the end. I think in 2017, literally 9 years later, there was a significant departure from the language of verticalized programs, where the WHO Afro report in 2017 urged a holistic approach to strengthening health systems, moving away from the verticalized program-specific approach of the MDG era. I think that this was a document that spelled some difference, and in fact laid out the idea, talks of inputs, outputs, outcomes, impacts, as is so common in performance management documents. But it then raised the question of we need an efficient, integrated, person-centered delivery system with intersectoral collaboration. But how that happens, there's no information being provided. I think that another document provided at that time talks, again, it was a pamphlet that talked of person-centric care and the fact that one needs to deliver services to people across the range of healthcare, to all populations, especially those marginalized, and to target all age groups and all health risks. Certainly the beginnings of a generalist approach in healthcare, universal health coverage, and primary health care. Again, not clear how that's going to happen. 2018 WHO Afro resolution also brought forward the idea of financing, and I think very important ideas in financing, something that's been commonly talked about increasing domestic finance, but bringing up the idea of prepayment modalities, which I think are not used very much and increasingly being embraced by African governments. Importantly, to transition away from external funding, financing, especially aid funding, and to improve the efficiency of health spending. Again, how do you do that? And then delivering essential healthcare services and also gathering data. for UHC. In 2018, there was this document, contribution by WHO to the WHO Global Report around Astana. And I think it raises the challenges that even despite calls for decentralization that are literally 10 years old in Africa, governments are not handing powers of finances and HR management over to the lower layers, those districts that they talk of. And then they also find themselves having very limited capacity at these lower levels. So it's a chicken and egg situation. You know, you're not going to get power, not going to get capacity if you don't hand power down, authority down, and the same on the opposite end. So I think there's clearly a need for a very sort of incremental approach. Otherwise, we're dead in the water in terms of building up strong decentralized services that are responsive to communities. In 2019, the State of Health on the WHO Africa region said there's a worrying underperformance on several levels, and this was prior to COVID-19. And in fact pointed out that much of the terminology in the WHO around 6 building blocks has led to verticalization, and that one is not talking about how do you build interactions across these, or talk to how do we build up person-centeredness in a much more clearer manner. And all that is happening in the last few years in WHO Afro has been flagship countries building up and sharing of resources between these countries. I want to share an important report that was developed by the Africa Health Agenda International Conference. It produced a report by pulling together commissioners. I was one of those commissioners. And that report basically in 2021, earlier this year, pointed out or talked to 4 things: that of performance of Africa versus the rest of the globe, the challenges we experience and the opportunities. And then it offers some recommendations, and I want to go through those different elements. In terms of UHC performance in Africa, you know, we know that coverage is poor, with low coverage effectively, quality inadequate, inequity in that coverage, with rich actually benefiting more. Financial risk is also not good, and in fact almost 1 in 10 people in Africa have a catastrophic health expenditure per year, which is very poor compared to the rest of the globe. Even though our health outcomes are improving over the years, globally it is still at tragically poor levels. The context of the challenges that we experience in Africa, I think we have challenges in our context that I've talked of before, which is the legacy of colonization, the neo-colonial influence, and the inadequate economic growth. We have been growing, but not good enough for our population, which is growing very fast. And I think we have a high dependency rate, which is a family being large and the number of people working being small. And so high dependency in communities, which can create tension if we don't, political unrest, if we don't decrease the dependency ratio and make more people economically active. We also suffer in Africa from a context of political instability and wars, and rising and unplanned urbanization. I think corruption is part of that challenge, where we're not getting this kind of systems in place to cater to the changes happening in our continent. I think in our plans we need good governance structures, and I think this is part of the challenge we have. So climate change is another one that's going to stir even bigger migration shifts to cities and create bigger challenges with slums, etc., if we don't have good systems in place to deal with it. At a system level, certainly in the health sector, there is very poor management. We have very poor governance and accountability of health systems, of health managers. We have a high disease burden, and we know of that. But we also have very poor trust and ownership in health systems. We also are challenged by some societal practices that become difficult to manage in our health system. We also have opportunities. I think Africa is certainly a place for the future. The next century may be Africa's century. We have an economic trajectory that is really growing and growing fast, and many people are noticing. The African Union is proving to be much more pro-people than the OAU before that. And a more important achievement has been the African Free Trade Area that is going to create the single largest bloc, economic bloc in the world, and I think promises great economic benefits if we get it right and it actually does fulfill all its ambitions. We also must see our network of traditional healthcare workers as an opportunity. I think certainly the political commitment evident in the EU deliberations is something to see as an opportunity. And then despite the sort of fear of our populations growing dramatically in the next few years, I think we must see that as producing young people who are going to be much more working age and produce the next century's benefits. And we should see that as something we should be now investing for our future generations, African generations. I think other opportunities in Africa that we've got to acknowledge is that we have a vibrant private sector. It certainly produces lots of benefit to for health, especially in our continent, and we need to see them as part of one of the players in an overall health system. We have lots of innovations in Africa, and I think there's an ecosystem that we need to encourage and see as an opportunity to frog leap the legacy challenges that the globe faces. We do have a strong civil society that we need to build on, encourage, and we as AfroPHC are part of that. We know that we have very well trained and very competent health professionals. Unfortunately, the continent's governments are not utilizing them well, not directing them well, and I think many of them are leaving the continent, and they are very well appreciated in many other health systems across the globe. We should see opportunity in the COVID-19 that it has actually jolted a lot of our healthcare itself, and that we've been responding to try and strengthen the health system, and we need to find ways in which we use that conversation to locate primary health care going forward. The Hague report recommends several things for universal coverage to be achieved in Africa. And I think there are specific health recommendations. These are to reorient the health systems towards population healthcare, where currently there's a strong focus on patients and certain focused, target groups. And here they are saying we need a much more comprehensive system that includes prevention and promotion, and that we need to prioritize and strengthen primary health care. And this should be strengthening it in in terms of our overall health system, to prioritize it, but also to look at health in all policies. And this is about integrating the health in all policies across all government sectors, and to create a strong developmental and decentralized government, and to push that agenda across the continent with all governments. I think there's, like was said before, the need to reallocate existing health resources away from hospitals and care that is designed for elites towards primary health care that is equitable and in fact across serving the entire country, and to increase investments, especially to strengthen primary health care systems. And this is the way in which we're going to reach good primary health care and universal coverage. Continuing that idea of prioritizing and strengthening primary health care is to strengthen PHC facilities, and I think that is about looking to get access, that people have it near them, but also make sure that there's a strong link between populations and the clinic itself or the facilities themselves, with strong support systems that especially for referrals. We also need to strengthen primary health care service delivery with multidisciplinary teams that are flexible, not hierarchical, that are multidisciplinary, and that can include clinical and non-clinical staff. And they should be supported to provide integrated care to defined empaneled populations. And that's the text from within the Hague report. And it also urges implementing integrated models of care service delivery, where we have contracting and reimbursement that actually tries to achieve this integrated care around a impaneled population and a team. Other suggestions or recommendations for Africa in terms of UHC and dealing with health is to invest in strengthening health system inputs, especially for prime health care, that's skilled workers, infrastructure, commodities, the information system, as well as looking at system-wide approaches, which are governance, health workforce constraints to quality, which includes accreditation and certification procedures, education, supporting education, etc., as well as resource constraints to quality, whether it is within the health system in terms of availability of drugs and equipment, but also rural constraints around roads and transport, etc. And I think in health to change the financing, where not only do we increase the domestic finance, that we pool funds in a way that improves and reduces the fragmented funding that occurs across the continent, and considers strategic purchasing, which is a way to separate the funder from the provider and build in lots more accountability and competitiveness, where the patient actually can choose and force changes on a very unresponsive health system, and where the manager sees the patient as the boss and not the manager above as the boss. And I think to do that, we need to get reforms in public management finances, and there's a lot of inefficiencies broadly and in health that needs to be addressed. And I think to prioritize a systems for health approach, rather than looking narrowly at health just in the health delivery, service delivery or primary care system. Other recommendations are to strengthen governance and accountability, especially political commitment, and seeing health as a cross-cutting development strategy and across all government, and that it should be seen as health in all the different sectors, and that health should become this overarching purpose to government, and way in which it can build up on all the other various policies. I think to do that needs very comprehensive legal and policy frameworks, and also leadership capacity that we need to develop. To continue that, we need to see government as not just delivering in the public service, but to bring together various stakeholders across the board and to manage them and plan to manage them, as well as leveraging and governing public-private, which might include non-government partnerships across the board. And to do that where you can actually decentralize and empower people, communities, non-state actors to be able to take up the slack of delivery, and then to be able to create strong governance rules, regulations around that include strong anti-corruption strategies, and that through this you can strengthen community participation and create an equity agenda across government. Included in these recommendations is health technologies, and we should see health as much of a right of anyone, health data, information, accessibility, that internet is something that is as important as electricity and water. And we need in countries to build up the physical infrastructure, especially for that data to flow easily, for the country to have capacity to manage these as well as to regulate these, and to look at ways in which you can not try to deliver everything, but leverage off innovations and non-state actors to provide digital solutions and create that framework within government to do that. I think there are also some important recommendations at a government level, that government needs to decolonize health policy and make sure that institutions of health across Africa, whether it is the academic institutions or the accreditation and certification institutions, that they should not be hung up by British standards or certain other ways of doing things, and be willing to explore different ways to do it that breaks their ties with these kind of colonial antiquities that exist in some of our systems. I think it urges investment in manufacturing health commodities and investing specifically at a government level in the young, at health and also in education and economic opportunities, because that's the demographic dividend. If we can get young people today to be very productive citizens, then the next century is Africa. In fact, it could be by 2050 that we see such benefits emerging for Africa. So our population growth doesn't need to be a threat to our long-term prosperity. I think climate action is certainly something we need to look at, and I think all of this needs to be underpinned by research and development. And as you can see, currently the conversation in Africa is nowhere near dealing with the heart of this problem of service delivery. Lots of system inputs, outputs, outcome talk in our major documents, but nothing really detailed about how do we deal with population health management. No discourse around how do we empanel people and how do we link them to facilities where we have team-based care organization that is strongly composed and linked to this panel. We are not talking about how we can deal with access around the not only the geography but other ways as well. We're not looking at whether there is the available primary health care resources and provider, who is the provider and what is their competency. This data is not even available at country level across none of the other African countries have this kind of data clearly available. And so we need to actually start at very simple levels to unpick this question of this black box in the eyes of politicians and managers, and to see how we can rearrange this to be servicing people where we can get what people are at high level are asking for, which is good first contact care that is accessible, continuous, comprehensive, coordinated, and person-centered. And there's lots of measures in these spaces, but the big problem is, and the PHC Performance Initiative is actually trying to unpick that black box to see how we can get there. But there are clearly no plans in place to see what we can do in that space. How can we deliver? And I think policymakers are battling in that. So as the African Forum for Primary Health Care, we consist of a range of the multidisciplinary primary health care workforce stakeholders, including community and community organizations. And we are across Africa, 40 African countries, with almost 1,000 people that belong to this, some very, very wide range of very, very strong leaders. And what we are advocating for is primary health care that is appropriate and that is strongly working towards universal coverage as the global call goes. So in the AfroPHC space, we have been looking at the conversation, not trying to prescribe, but trying to build it from all our members as to how do we go down this path and develop solutions that take the agenda forward. I mean, we started off last year asking the question, well, who are we as the team and how do we work as a team and who is in the team? And it came out very clearly that, well, everyone needs to be part of the team. There are lots of team members, but that there are layers and ways in which we can build up the team as we proceed in building up universal coverage. And I think these are various issues that will be incorporated into a document on building the primary health care team in Africa for UHC. So let me add some ideas that we've been trying to incorporate or looking at and that serve as inspiration for the kind of how that can be done, and in a broad document. And in Shewelo, where I work, I am basically set up a community practice. And it's important to understand it's basically looking at how can we do exactly that, panel a population to a dedicated team, and how can we achieve results, and how does it cost, and how does it work. So let me say this is not new ideas. This is actually coming from the CARC's work in 1940s in South Africa. And it's really much a replication of what they did. So the CARCs in the 1940s had two innovations. They worked with a population of 30,000 people in a rural community of Polela in KwaZulu-Natal at the time. And essentially they had two innovations. One was a community health center, which is most of what we understand and happens in primary health care, where they, as two doctors, had medical aides and nurses coming to the team, and they task shifted and delivered medical care to that population of 30,000. And they did a wonderful job, and they managed to deal with a lot of the clinical problems, the medical problems of that community, where the community would line up and they would provide care, and it was useful in that sense. But the CARCs themselves asked the question, is this primary health care as we think it should be, as preventive, promotive, or is it just medical care? And clearly there was a need for more. So what they set up is what they called community-oriented primary care. And so for that 30,000 population, they basically took 1,000 people and they paneled them into a practice. What they did is they said, you will come to the service and we have a record keeping system for you. And in that record keeping system, anybody from that community, when they were seen, they had a clear record keeping that produced a benefit in itself. And they would then deployed communities into that community, collecting information in each household, understanding what goes on in everybody in that lived in that area, and engage with the key stakeholders, had these people come to the clinic, and then they collected the information from these different sources, from the community health worker profile, from the stakeholders when they sat together with them, and then also with the clinic and the information they gathered in their notes. And that basically information they took to the community stakeholders, and then together crafted health promotion strategies that would advance the agenda, looking at nutrition and seeing the number of people that came through and the kinds of problems that needed to be dealt with, and looked at the community and said, let's try and figure this out and stop by gardens, etc. Lots of health promotion they did. And this was basically the community-oriented primary care, and we simply replicated that. Each year they would add 1,000 people, and each year they would measure those who were worked on for the year and the new people, and they could see a difference between those who were benefiting in the years that they were getting the service and those who didn't get it. And it was much better, because even with their medical help, there was clearly improvement in the quality of the outcomes from their community-oriented primary care. So this laid the basis, in fact, for public health and grew into a discipline of public health. And I think its roots in marrying community-oriented primary care, which is public health and clinical health. I think public health has moved quite far away from this kind of conception. And as family physicians, we see community-oriented primary care as a very important concept, and it brings public health and clinical health closer together. So in Shawelo, in COPC, we basically have tried to look at how do we combine these ideas of population management by community health workers, PHC reorientation, stakeholder collaboration, and targeted health promotion, and do that together in a way that's iterative. We're juggling all of these at the same time, but we keep these four things in mind as how do we use this to drive the process forward. And it's been very helpful to respond to shifts and change and the uncertainties that exist on the ground by just keeping these four drivers. Most of my time as a clinician in that space is actually around the primary health care service. So in 4.5 days, I'm seeing patients or teaching around it, or etc. But I work once a week with half a day with the community health workers to try and help them, to link up with them and to find ways, and I teach them, educate them. And I don't need to do it all the time. I can delegate it to others, but it's a link to the clinical team. The community health workers, on the other hand, I spend a half a day with them, but I'm really looking at getting them to manage the population, collecting information, and I can share more about that. And then stakeholder collaboration I do once a month with a meeting, and then we look at targeting the health, developing health promotion that's targeted based on the information we get from the clinic, from community health workers, and from the stakeholders. And we spend about weekly meetings and then once a month in trying to refine that. So let me talk about the population management. Well, the community health workers are deployed. They can see, this is a map, Google map of the Ward 11, where the community health center, Shiawelo Community Health Center I work in, is based, located. And we've got community health workers that are deployed to different streets, and they go out there. So 15 of them into this area of a couple of streets. What they do is they go into this, and initially we got them to go with to do a sort of summary, a street summary, a census of the community to pick up where we are. And then later we got them to go into each household and do a registration, and then to collect information per family and give them a letter inviting them to say, you are now registered into the panel, you belong to us, and you know where to come. Tell them where to come. And so that began the journey of the community health worker, who then continued to work with that community that they were allocated to. So we had 15 community health workers. We had them in the Ward 11, and we did the survey in the community, the census, and there were about 22,500 people with 4.2 people per family, which was really very different than we thought. We thought we'd find 10 people in a family. That was the idea. Yes, the family has actually become smaller, but the density has remained within the particular lot. We found through conversations that, in fact, it was a granny with one problem child who couldn't move out into their own post-apartheid with a new RDP house, and there were usually orphan children that were part of the equation. But what was Granny doing? She was hiring out the little extra rooms and also putting up shacks to try and rent out to earn extra money. Well, the community health workers registered 18,000 people, and it took a while to get there. And eventually that was their base out of this 22.5. And it's constantly being, reviewed, where new people come in, people leave, and so it's refurbished. So that's our 18,000 people. But in the registration process, what we wanted them to do was to see through the forms that we got from government is who are those at risk. We want to see those who are ill, who have illnesses, and we want to link them, if they're ill, where they're getting care, link them up to us so that we can provide them care. But we also wanted to pick up those who are at risk, because many people feel healthy, but actually we need to screen them. We need to see whether they have risk at primary and secondary care, secondary preventive levels. So I think it's about thinking through the conception of risk much better. So in terms of population care, we have a household registration form. This is actually a tool that the National Department of Health provides, but it's limited. It's useful in that it collects some information. Each person in the household understands the household in terms of employment, etc., but also some of the context like electricity, water. It does ask some screening questions, but these are very limited. Part of the challenge is that it's collecting information in a family, and so the data is not very useful. We also get information from other sources. This is, for example, information we gathered from the census, broad country census, and give some sense of what's going on, and in a way you can correlate it to some of the information we've got. Unfortunately, some of the information that we collected around household employment and grants, etc., were not as accurate, and so it was quite difficult to figure this out, whether it is exactly what we are getting. And I think that what we found is that many of the community health workers across the country are just collecting that information, piling it up, and then moving on to simply report on visits after that, with no real clarity as to whether they did a good job in the first place, what they collected, what they're doing about the problems that they found. So it's entirely dependent on community health workers to see if there's a problem in the community. And there's no real link between them and the facility at all. In most places. What we do is we actually have spent time with the community health workers and helped them to collect and collate that information in a way that can tell us, what they found as a problem and whether they've followed up on any of it, and whether there's a resolution to some of them. This is how we have performed up to a point in the Shiawelo Community Health Center, and as you can see, that it is useful in that we can see that things are being resolved. But for example, the number of deliveries over a 3-year period nowhere reflects what should be found in the community. Lots of that is poorly captured and poorly picked up by community health workers. Lots of the focus is on on chronic disease, and they tend to pick that up quite well. And there, for example, even there too, the number of people with HIV depends very much on whether Gogo knows everybody who's got HIV in the family, and not always the case. Even diabetes is much lower than we know is in the country, largely because not everybody seems to know. And I think that is one of the challenges with this kind of data collection process, which is family-based and universal across South Africa. So a lot of the challenges we've found as we've proceeded with this data collection is that it's not individualized, it's not robust enough in the collecting of the kinds of information that matter. And I think that a lot more can be done in terms of improving the data collection in population management, and also the way in which we work with community health workers and get them to fix up the issues that we think they need to fix up in the community. But there's strong relationship between the community health worker and the primary health care service, which is really quite an important element to it. So in the facility itself, with the community health workers and us meeting very strongly, and in fact they are very much part of the team. We've in fact with a small group of the community health workers been able to run this place, and that's one doctor, a clinical associate, and 2 nurses have been able to look after this 20,000 people, 18,000 people, and provide as comprehensive a service as possible. And this basically covers a range of things like that we can do as a team. There are obviously things that we cannot put into that small building. So you can see that there's large community health centers like occur across Africa, with a multiplicity of services that are very segmented. We in fact took half the building of the one that was dealing with child health at some point, and in it we basically created a practice environment that looks after these 20,000 people, and have done that quite effectively. We do refer and use other services, referring patients to them, because the nurses, for example, in many of these services have refused to come along and allow us to provide these services. For example, mental health, we deal with it, but then sometimes we refer. So we do structure it in a way that's much more better, where we have appointments. We try and encourage appointments in the population. We get the community health workers to do it, and they manage the whole system, where we get written appointments, even using a simple telephone, and running it with a paper-based system. And 50% of the patients at one point were booked, and 90% showed up for the appointments. And the waiting times were like half an hour for both those making appointments and those who didn't make appointments. So it had an overall improvement for just making appointments. We also have structured a very clear family record keeping system with a family folder. It has individual folders in it within the patient family folder, and where there's a strong problem-oriented medical records approach. We also include chronic care process in it. But importantly is we have a community health worker folder that's a separate yellow, different colored folder, where we take the form that was used in registering the family. And so the first member of the family, when they come in, we pull out that form from a folder of a file of the forms by the community health worker, and we put that into the patient's folder, the family folder, and set that up for the first time. So as a doctor and a nurse or a clinician, I can basically see this family as a family, if there are 2 or 3 people in the family, and I can look at what the community health workers found in the community. And I can then write notes for the community health worker to say, please, for this patient, I want X done, and please follow up or do X, Y, Z in terms of this patient. And it's something we encourage all our clinicians to do that, especially the interns who change every 2 weeks in our service. We've been able to provide a wide range of services, largely because of the medicines that are available in a community health center, and also try to provide procedures which improve the quality of care, the comprehensiveness of service. And most of the time we're limited only by the simple equipment that we don't have, that would be easy to procure and manage in a team with systems that we can build up. And I think that's the opportunities available that still are not used very well. But the patients experience first contact care that is comprehensive, coordinated, and continuous through the efforts of a strong team-based approach using the kind of teaching simple approaches that we encourage in family medicine. I think in terms of reorienting, we've also used very strong record keeping systems, including chronic care and protocols. And all of this has been quite remarkable, even though we have anecdotally patients saying, we love the service, we're always coming here, we appreciate the short waiting times, the medicine availability, the quality of care. We've found that our utilization is very low. Kind of disturbing idea when you consider that it has been less than one visit per person per year in the population that we have. What we've found is we thought, well, we're not really providing access, they're not happy with us. So in a study we did in the community, a randomized study of the entire sample of the community, we basically found that patients were coming to us for 97% of the time, and that they used the community health center 7% of the time, and most of that was actually for services that were things that we weren't providing, like mental health, dental health, etc. But they also said that their utilization to us, that their visit rate was in fact equal to their needs. So whenever they were sick, they came. It was very linearly correlated. But they did say that when we asked them about whether community health workers increased their visits or reduced their visits or left it the same, 44% said that the community health workers who were very strongly linked up to us had actually reduced their visits. We also found that they found it's very accessible to come to the community, to CCP, and were very satisfied with it, as compared to the community health center, which they found very inaccessible and very unsatisfactory. And we did a separate study on the chronic care within this Shiawelo community practice, and found that we were far better than the community health center was doing on HIV, on hypertension and diabetes. We were more or less similar when it came to HIV care, because that's still a very verticalized service within the community health center. So we were having a very strong practice. In fact, people claim this is our NHI practice, this is our private practice. The third thing is stakeholder collaboration. And stakeholder engagement started off right at the outset when we community health workers were going around mapping the community, registering and screening. They were asking patients, who do you think is important? And so we built up a profile of the people that are important in the community. We also then went into the community asking who are stakeholders, and starting with the councillors, ward committees, parties, and then just snowballed to ask who else is important. And it turns out, people at schools, the police, etc., etc. So the health system, certainly there were key people that we needed to link up with, whether the hospitals, local clinics, other clinics, and GPs. We tried to link up to them. We also looked around to see, well, who are other sectors of government in this vicinity, and to talk to them about health in all policies. And we found them: education, department, the social welfare department, even police service, and then agricultural department. So like that, we tried to do that. We actually even went to a very high level in the province to try and say, you're talking health in all policies here and intersectoral collaboration, but we're struggling to get the right departments to engage with us at this low level. And clearly that's the problem in governments, is they cannot percolate that. If they try to do it in a sort of top-down way, it just doesn't happen. And they need to look at how that's encouraged from a bottom-up approach. But it needs policy to think like that, policymakers to think like that, and they often don't. Well, we tried to bring this kind of stakeholders together in monthly meetings, sometimes quarterly, and it's been difficult to get all these stakeholders into one meeting regularly, monthly. Our staple group is in fact our patient groups, which we've created through our health promotion efforts. And essentially at that meeting monthly, we are giving them feedback, allowing them to give feedback on the quality of care, the problems they're experiencing in the care that we are providing. But we also then say, what about, the agenda that we have of health promotion? And so strong engagement with the community around what we should be doing in terms of prevention across the board. We also, once a year, considering especially this challenge with getting everybody on board all the time, as is common, when things work well, people stop voting, they stop going to meetings because, somebody else is going to sort it out, and most things are going well. And I think that's the feedback we're tending to get. But once a year, we've been trying to have a stakeholder workshop where we say, let's prioritize the problems to help us for the rest of the year. And it's very open, and it's actually mostly developing the priorities for the community. And every year every time we've held it about 3 in the last 6 years. Every time we do it, the same priorities. I mean, the way we started it, we say, well, let's talk about what your problem is with the facility and the services. But then after that, we say, let's forget that now. And let's talk about everything else that's outside of the health service that's impacting on your health. And number 1 is poverty and unemployment. Number 2 in our community has been drug abuse. Number 3 for 2 years was teenage pregnancy. And then on the last time, it was the environment. So clearly, these are important health priorities developed by the community in a very engaging process, and that help us to then take the process forward. And it's become, as I said, part of the equation to say there's information from, the community health workers in the community, profiling the community, what patients we're seeing and the data collected that in around the patients, and then stakeholders, what they think. And then we try and put that together in weekly meetings with the community health workers and monthly reviews with the communities and annual reviews with the community, and find ways in which we can do things that actually deliver on health promotion. And lots of very good ideas have come up and that have been implemented across this community over the years. One that worked really well, a walking club that's become now a health club, 5 clubs set up in this community, which is a small geography. It doesn't have a lot of people, only 150 totally out of the 18,000, but it's important source of support to the community, not just in the way of getting people to exercise, but actually as a social support system. Many of them have actually gone on to become NGOs and develop other support systems, teaching arts and crafts, becoming an NGO, doing soup kitchens, etc. We've actually tried to link the community health workers in that process to chronic care delivery, especially around COVID-19, to get chronic care support, use that as a support group as well. We've tried to set up food gardens, hasn't worked very well. Cooking classes also have been challenged because of the resources we have, which is nil. And also setting up a school league with an NGO, and looking at youth clubs as well with them. And then looking at opportunities, that are free, like Facebook, WhatsApp, to be able to communicate. And I think these are various opportunities. And I think that the challenge has been that managers have not been very helpful and in supporting us, and in fact pulled out community health workers that were dedicated to some of these, saying that no, their job was to be doing X, Y, Z. And so that was not acceptable to the managers. So this is what our idea of community practice is, because it's about delivering care that people don't see as usual care. It's not the usual private practice, but it's also not the usual clinic. It's a combination of the two that builds up in a very sort of complex adaptive system by a team that works together closely and responds to these various challenges using these drivers in a way that really delivers the goods. If we can keep the high level outputs focus in the process. Well, before I come to the sort of proposals that we're making, I want to just say that across Africa there's a growing move towards shifting from budgets and salaries as the way to pay people towards looking at other ways to deliver. And I think particularly capitation, performance management, performance-based payment has become a top up to that process. And in the private sector, there's a fee for service where I come and I give a fee, and a patient, I give a service and a patient pays me a fee in the private sector. So this is the kind of combinations that are being used. And in very few places in Africa, we're getting really good, strong capitation, which is really a strong basis for good health systems, primary healthcare systems across the globe, and in which is growing across the globe. And mostly capitation is about prepayment. It's about saying, I will give you a per capita payment. Usually it's a monthly payment in advance to take care of a person. And that person, if he moves from one practice to the next, will move with his money. So in a way, that person is the money. And so the care is to the person, and so it's much more responsive, but it's also not, it's allowing the doctor to incorporate, or the team to incorporate all the things that are not paid for usually by fee-for-service systems. Budgets don't create a responsive system. You worry about who pays you, not the patient. And fee-for-service is prone to abuse. It's very responsive to patients, but there's no controls, especially with the fee for a service. Whereas a capitation system, which includes fee-for-service, performance, and sometimes budgets, can become a very powerful system. And usually we talk of mixed capitation. So many parts of Africa, we have basically populations that provide their funds to the national treasury, even indirectly through various taxation, and these go through to the provinces or other denominations across Africa at subnational level, and then usually some of that money may come down to a district, which then is running these various community health centers, clinics, and maybe at some arm's length local government and non-state actors who are running their own clinics, and it varies by proportion across the continent. But that's more or less what goes on across the continent. And very separately to the system which the population uses is some few people have access to medical aids or insurances, privately funded insurances which run through private administrators, and who pay these directly to the care providers through fee-for-service usually, or the person themselves, using the cash in their pocket or other means, will pay the care to the GP or pharmacy themselves out of pocket. And I think this is the kind of very fragmented funding and service delivery that's occurring across Africa. And in some places it's quite dominant that you have medical aid systems like in South Africa. But across Africa, the public-private divide is a very notable one, and the private spend is quite large. And many of the governments are not appreciating that they need to be custodians of the entire health system and to move away from thinking only about the public system. And so strategic purchasing is an idea that's come up, saying that one needs to find ways in which you separate out the control of the services from the payment and the purchasing of the services, and that there needs to be a pooling of funds in governments, in countries across Africa. And the idea is still that populations will be taxed, hopefully by providing a satisfactory service that covers all the public-private facilities, that those who pay out of pocket, and even those who are having medical aids, might find themselves spending less and being willing to contribute to the national treasury, that can then send funds through a pooled fund that is a national health insurance fund, as an example. And in my view, we should be looking at private administrators to support that process, to support this national fund, so that it can be able to manage these payment systems in a better way, where there is very limited capacity, even at national level, to manage many of these systems. And then to take the burden off the district, where the district no longer is now going to be responsible for running services, but in fact allow the service itself to be grouped, so that smaller facilities can group together and be supported in that process, and local governments themselves and national non-state actors and private sector can become providers in a system where they contract with the national health insurance system in a way that can be very universal across the country, with very little in the way of contracting actually happening, except once and then gazetted changes happening annually to provide changes. So it really is very strong legal kind of environment to create providers who then will get, or based on a very, very specific and clear contract, that they have to produce the goods. And of course, the whole challenge will be in the public service is how to get these public providers to be grouped or to be supported at a local level to become entities that are public service, still publicly owned, but have very strong accountability in themselves, both to the communities and to the public system as publicly owned facilities. But yet, as a provider, they are not being told by the managers at a district, no, you will do this and you will do that. They can respond to the patient needs and the community needs in a much more effective manner. And that is really international best practices across the globe. So I'd like to propose something that I proposed in South Africa to the National Treasury as a framework for contracting. And it is saying, let's move away from this idea that a clinic or a GP is just a facility-based, a curative approach to a technical or sort of hypothetical catchment population of 10,000 towards a community practice which has an enrolled population. And this can vary. It can vary over time from small numbers to higher numbers and be sort of staged so that it does produce the effect of equity across the country and also addresses the challenges that providers may have in embracing larger populations. But I think that it can be built into the contract and develop strong performance accountability. And using the same 4 principles I talked of in the COPC and the Shiwelo Community Practice, which is to understand the population, understand how they use the services, engage with community stakeholders and build the priorities together, and then embark on targeted health promotion based on a community diagnosis. And this is essentially, the idea that one needs to gather services in a way that produces the results more than we have at the moment. So at the moment we have lots of clinic services that are very curative based, most of the time doesn't produce the right kind of service. So our proposal is that there should be an accountable doctor for a population. These combinations of population to doctor, nurse, clinical officer is something that can be developed per country. It could vary per country, but at the end of the day, it's about a strong team that works for a defined population. And in our view, it can be a clinic or a facility with a doctor that's either employed or a doctor that then develops that team around them as a private provider, or even nurses who come into a configuration with a doctor to provide that service. But clearly the importance, we need to actually spell out what is the requirement in that. But it can provide what is the most valuable services. Many a time we talk about a service package, but really what determines a service package is not a list. What determines a service package is the competency of the clinical team, as well as the rest of the team, and the medicines and the ability to refer and the kind of lab tests that they can do. That decides the service package. So if you define some of these few things, you'll actually get most of the service covered. You don't need tick lists and function like that. So you need to appreciate the importance of professionals, the complete professional team around the community primary health care team that can slowly drive the right kind of outcomes. And that's what they talk to. And you can easily add new layers of services as you think through the process and cost it out and build onto it a bigger and bigger service packages based on the human resources that are needed and can do it in a very cost efficient manner. And as I said, this package can be defined by simply guidelines, which are many, especially the primary health care service guidelines within public health service guidelines. And there are those in South Africa. It can be defined by a medicines list, labs list, a procedure list, defining exactly what they are and what they'll be paid for, and even preventive services, exactly what an antenatal care visit will cost and what a family planning service will cost, with the overall service being provided covered by the capitation, which should be paid for by 70% of the payment overall, and where fee-for-service is only covering a smaller element of the service, and that should be these preventive services, procedures which are relatively limited, any labs and medicines, and that on a clear claim basis. You also need to have a payment that's defined by that includes performance outcomes, and I think it is including that is something that could grow, and there's more details if one wants it. And you can review the service package annually by bringing together the peer review systems, the way in which one can at higher levels get a service benefits committee to define that better, and even an institute that does builds evidence around value for money on lots of new services that might be provided, and it can be for medical schemes one of the services that they are forced to provide. Well, in terms of setting this up at the National Treasury, I proposed some key principles for delivery and some operational principles. They basically start with clinical teamwork, community orientation, referral support, district coordination, and supply side innovation opportunities. So in terms of clinical work, we need, this is written into the contract, that we need to encourage clinical teamwork. It cannot be that people think, oh, well, I'm a doctor, I only deal with this small number of patients and that's it, I'm happy. We need to force them to actually get other members of the team part of it, and we need to push them to actually take on more people in the panel. And we've actually suggested that there be one doctor per 10,000 in South Africa, and that be the clinically accountable doctor, that there be at least one clinical officer associate in South Africa per 5,000, and one nurse per 2,000. This is at least a minimum, and that all of them be registered, and that they be able to claim in terms of data submission, which we need to have. So everything should be electronically submitted. We also want to have community health workers per 1,000 as paid for employed people of the team, and in fact we've proposed other bonuses for multidisciplinary teamwork, but depending on the resource envelope. And I think that just to share the importance of the COPC experiment, if one were to look at the assumption within South Africa of 4 visits per person per year, which is operative in the private sector, this practice of 10,000 would be seeing 160 patients. But when we look at the public service at the moment, they're seeing about 80 patients. But if there is this new system, they might grow. But with COPC, we've actually been able to drive the utilization right down to below 1, which means that instead of seeing 160 people, we'll be seeing 40. And that's an enormous impact on the rest of the team, which is about how we compile the team. What is the numbers we need? So utilization rates and the way in which people are trained to function, especially with community orientation and skills that family medicine is teaching, these will make a huge difference to the costs of operating in a universal coverage system that we're describing. So the community orientation includes being able to manage the panel population with community health workers. We've in fact added into it that there's a mandatory comprehensive health check which will be paid for everyone in the panel, so that everyone, not just the patients who come in with sicknesses, but every single person in that panel must get checked to say, have they done pap smears, have they done, and this should be done for every 5 years, so that there is a way in which this can be forced, and that it develops the culture of comprehensive health checking amongst the population. And then to engage in community for targeted health promotion. And we've actually suggested annual panel community meetings, a monthly community forum, simple practice leaflets of services like is done in the UK, and then a detailed annual review of the practice, which should be put up in the public domain. And every practice needs to have a website and be told you put it up there, and anyone in civil society can go and review that information, so that we can see what goes on. So it's not just a person at the top in a government department that's getting this. In fact, it's society getting it, and there's a much bigger transparency in the process of care, and less need to be supervising all this detail. We importantly want to make sure that there's no discrimination between those who are patients, that somehow those who are much better paying patients get better services than supposedly NHI patients. We also want to encourage the home visits by doctors, but that is nominal. We also want to manage referral, because that's a clear need amongst any healthcare provider. There is a serious problem of over-referral. That's one of the moral hazards of capitation, that patients will simply be sent quickly to higher levels of care just to get rid of them. And that's why we propose a referral point, so the referrals are actually clear. It's actually a referral network that a doctor or the accountable doctor, who's the referring person, will have to send people to, and that's a network of whether it is doctors, specialists, hospitals, allied healthcare, etc. And I think that this can be the actual process needs to be electronic and managed, and it's available in South Africa and in fact across Africa, and that there should be a way in which we in fact collect this information and build up an understanding of the number of referrals and the kind of referrals, and find ways to actually review that. And I'll talk to the review just now. District still needs to coordinate, and I think it needs to bring these service providers into a forum that's including public, private, non-state, any group that's registered as a provider needs to come together, become as a community practice, and be able to be part of the discussion about program priorities, so that we can find ways in which these various priority programs are integrated into the practices behavior around patients, but that the way they function is person-centered, caring for people and families in a very personalized way, and then they look at ways in which these programmatic priorities are actually integrated into it around the patient. The district must also look at how it can support the referrals around the practices. I mean, supply side innovation is actually quite important. We need to be able to see how this performs financially, and that we can understand the premises and explore various other elements to it in layering additional services, including, for example, after hours care or emergency care or additional dental care, etc. And I think these are various opportunities that one can do to explore, and I think that gives us space, especially if we start it in an incremental way, in focusing on this layer or this peel of care of primary health care. And I think that it forms the basis for the kind of strong community orientation, so that even dental care, as an example, currently is very, very biomedical, very high cost. And at the moment, if you look at trying to figure out what the costing should be for a public health and national health insurance system, it's really very difficult. But given this scenario, one can actually start testing out some of these elements and say, how do you actually do it on top of what is a very strong community-oriented community practice to start with? And I think this begins that testing out in various ways to build up primary health care across the country. And just this model, after testing out, can be rolled out across the country very easily. And the process, what we've suggested, is simply make sure that people are setting up standards according to national standards, which is the Office of Health Standards Compliance in South Africa. They don't need to go through a hugely bureaucratic process. They can self-assess and send in their application, be accredited, but they can be under threat of losing that contract, because every 5 years there may be a visit. Not only one visit, a second visit potentially as well. But this is the idea, to try and make this a very strong accountability system, but also something that is very practical to roll out across the continent. We also think that enrollments is a huge challenge, and it's many parts of the Africa that has been the challenge. And so you require to get everyone getting a card, and that needs to be sort of ensuring that we've got a real warm body that's getting there, because one of the biggest problems in corruption of the system will be fake people, fake residents. So you need a way in which you gather all of them through as we do for voting, to give them, or IDs, to give them a card that they will then be able to take through to a contracted provider, hopefully within the district, that allows them to have much in the way of opportunity. There can also be some sort of administrative allocation, and then the provider themselves need to enroll people, and so one really gets all efforts going to get as many of the people enrolled into the system. And then the provider, when they come through to the practice, they would be able to then say, well, when you come through, you've got a card, I will then register you in as a patient, and simply fill in a form, send you through to the NHI administrator, and I then get payments. What we want to try and encourage is that patients are not stuck, or people are not stuck with the particular provider. So we recommend that every 6 months they change, and that they in fact look at secondary providers, secondary choices as well, and that one caters to some out of province visits at a nominal level, or to sort of accredited to other sort of providers that are also part of the system. And I think to manage the fact that there can be selection challenges, so anything that is changing the panel or closing the panel needs formal approval. We also want to include in this that it must be electronic, and we need all the fee-for-service data to be used through very commonly available payment management systems using electronic data interchange, which is very easy with internet connections across Africa. But what we need is a long-term plan to evolve to electronic health records, because this is utterly essential for stronger payment for performance, and we need interoperability issues. We need to also include mobile health for community health workers and integrate that with the process. An important element as we proceed is to make sure that from the referral data and the referral process, that those kind of accountable doctors from within the community practices in clinics actually participate in this meeting, where we can review that data and be able to see if in fact there's appropriate utilization, appropriate referrals, but not to do it in a penalizing way, but to in fact support them with education, upskilling and CPD. And I think that requires skills that family physicians should be having and should be able to support at this level. We also think that getting the family medicine training out there is important. The 4-year training of family doctors, family physicians is something important. But in the interim, we certainly want to advise the online work-based 18-month diploma, so one doesn't need to have all doctors going through universities and to train, but to actually do it while they're practicing in these spaces to get through a diploma in family medicine. We actually encouraged it for those who are less than 15 years experience, I think to create change management, to manage the change, and also to use the review process to focus their learning on needs that are really important for them. But importantly for us, we need to get them to understand how to manage the practice, as well as specifically to manage a population, as opposed to what doctors commonly do, which is just biomedical and focusing only on patients. We also need them to be the trainers of the team and to allow people in the team, in the local team, to be supported by them. We also need to look at ways in which we can incentivize younger doctors to go through and engage with this, and also make the diploma a substantial part of the performance for payment. This is a lot of information, but there's a whole lot more information that has been put together in a contract that has been developed for the National Treasury in South Africa, which is equally usable anywhere in Africa, provided there's a good political commitment and some capacity at national level. And it's got all the details that spell out detailed elements of all of this, and provides a very good path to advancing national primary health care in Africa. Of course, this is a easy contract. The contract's available. There's even a operation manual and a costing framework that's been developed. What governments need to do is perhaps to start small with some feasibility test sites, and to be able to look at setting them up with with good political project and management, change management strategies, and to look at how that can be really independently monitored and evaluated, and do that with setting up attended payment providers, which is the administrators. But one can, as you proceed, then tender out administration of the process overall. And to me, that is the requirement, is to be able to do these regular, relatively simple payments of capitation, very small, limited number of fee-for-service payments and pay for performance or performance payment systems, and then look at arranging operational supports, which is in fact around enrollments, drug access, lab access, and radiology access from the public service, and look at ways in which that might be available to all these providers without the current centralized procurement and human resource processes. I think at sub-district and district level that can happen. So if one takes a particular district and says let's pilot this, it can be finding these various providers, looking at a simple population, setting up a simple trust for the clinics and district management specialist teams to support them, and to get the district managers to actually support this process so that these providers can become robust and able to manage this within small populations. And of course, it'll work very well if there are multiple sites within the country, a couple of multiple sites that enable us to test it in different settings. And I think that one also needs a district level to look at support systems for enrollment, drug access, lab access, radiology access, as well as looking at accreditation and then the referral network that we've talked of and the way in which that would function. I think that for providers, it would be really important to engage with them, engaging with clinics, and ensure that targeted communities are prepared so that one has them ready to engage with the system, and then to tender out these practices to contracted providers once you've got and basically you'd be contracting with these providers. I mean, doing this is also relatively operationally simplified and can happen in any context within Africa. But I think that there's important work that needs to be done in research across Africa, and that's to define primary health care well, to be able to understand what are the personnel that we have, both the type, the numbers, and the distribution of the personnel across the country, to develop then these models of what do we think the optimal team composition is versus the population, and if we were to roll it out across the country, how might that happen in a very sustainable, equitable fashion across the entire country. And I think that once one has that idea, which details can be provided, one can experimentally test panels for the what exactly goes into the panel, to vary some of the sort of composition options, to look at what are the outputs and outcomes that we can get through it and the impact on a longer term basis. And I think that one can expand this testing in country to multiple settings and even multiple country settings across Africa. And I think this can produce enormous value if we have a clear vision that we know where we're going and that we need to focus ourselves on very specific ideas to be clear. And I think these conclude how do we find cost versus quality equations so that we can sell the advancement of primary health care in Africa. So thank you very much. This has been an extraordinarily long lecture. I hope you can relook it and will find it very useful together with the slides and the reading material that I provided. My details are here. Thank you very much and hope to see you sometime. Bye-bye.